All right. Well, it is 8 a.m. and I am absolutely delighted to have Dr. Jarjour present our guest speaker, Dr. Sola Olopade, and who will be talking about a really important area in world health, that is ambient and household air pollution. And for that, I will hand it over to Nizar.
Thank you very much, Lynn, and good morning, everyone. Thank you for joining us. Today, it's my great pleasure to introduce a wonderful friend and colleague that I have known for more than 30 years. Dr. Sola Olopade is a professor of medicine in the section of pulmonary critical care and sleep medicine, and is the dean for academic affairs in the Division of Biological Sciences at the University of Chicago. Dr. Olopade and I go a long way. If Sola could show that picture to show how long a way we have gone. So this is a picture from our residency days in the 1980s. This is upon our graduation, and you can see here Dr. Sola Olopade, his wife, Dr. Fumi Olopade, and myself. All of us trained at Cook County Hospital, and Dr. Olopade, Fumi Olopade, went on to become a very, very accomplished cancer genetics physician scientist, and is also at the same institution. After his residency, Dr. Sola Olopade completed a pulmonary and critical care fellowship at the Mayo Clinic. Then he joined the faculty at the University of Illinois, and where he remained until 2009. And as a tenured professor, he moved to the University of Chicago to lead their efforts in global health. As a director of the clinical program for the Center for Global Health, Dr. Olopade oversees global health experiences, clinical and research for trainees and faculty. He has also an NIH grant that supports research training opportunities for underrepresented minority students, both medical and undergrads. Dr. Olopade is a fellow of the American College of Chest Physicians and the American College of Physicians. He has served as the American College of Chest Physicians governor for the state of Illinois from 2006 to 2010. Sola is a superb mentor and has been recognized widely by his peers as a top doctor in pulmonary medicine, and by his colleagues and an accomplished physician scientist and humanitarian. He is widely published in asthma, global health, and the effect of air pollution. His research addresses the role of environmental and genetic factor in asthma, and Dr. Olopade is a member of the NIH-funded Consortium for Asthma Genetics in African American Ancestry population. His studies have examined the preventive strategies to reduce the effect of exposure of household air pollution for biomass, with biomass burning among women and children in rural Africa. This morning, Dr. Sola Olopade will speak to us on ambient and household air pollution, the unseen global threat. Welcome, Dr. Olopade, and thank you so very much for joining us.
Thank you very much, Nizar, for asking me to participate in this. And I remember fondly training at County Hospital, and one thing hasn't changed. You speak twice as fast as I do. So these are the disclosures and the support for the work that I'm going to be sharing with you. And what I was asked to do by Nizar is, again, this is the topic. What I was asked to do was to talk about my work, advocacy, and global health. And I'm going to capture this through this outline that I've put here. Touch a little bit about the historical context, because nothing is new. Focus on the concept of energy poverty as it impacts health outcomes, especially for those that are marginalized, and to look at the enormity of the challenges that are related to these exposures that most of us don't know about. And I certainly didn't know it was this big until I stumbled on it by accident. And then I'll talk about some of the work that we've done in Nigeria to bring attention to this issue. And for those who might be interested in global health, that's what I've done in the last 11 years. And it's been the most fulfilling time of my academic career. So earlier in my, as a young faculty, I was focused mostly on asthma. I still do asthma work. And being from Nigeria and being on the south side of Chicago, I was amazed trying to understand the differences between the expression of asthma in a high-income versus a low-income country. So at that time, I decided I was going to actually test this concept, the hygiene hypothesis, which is shown in this graphic. And it presupposes that children who actually grow up in low-income country settings, like I did when we were younger, we played in the sand and we were exposed to dirt a lot. That actually primes your immune system in a way that makes you less susceptible to asthma, especially if you have helminthic infection. I remember when I was younger, they would just come to school, whether you had worms or not, they just gave us helminthics routinely. And contrast that to children from high-income countries where you don't have access to dirt, everything is clean, people don't even want to get vaccinated. And the understanding is that all of this leads to overexpression of the Th2 paradigm if you are privileged, whereas on the low-income side, IL-10 magically stops the expression of this Th2 expression, so that even though there's a lot of IgE and eosinophils related to helminthic infection, people were not getting asthma. So I went to Nigeria to do a study. I collected stool sample, blood samples, did allergy skin testing, and then went inside the homes to collect dust samples to test for allergens. And that was where the serendipity came in. About 70% of the homes that we went inside to collect dust samples they were cooking indoors, and it was just difficult to comprehend because you couldn't stay there very long and the walls were just black. So I started thinking, is this really hygiene hypothesis, or could we be dealing with oxidative stress from this exposure to the high level of pollutants that were being emitted by cooking with either kerosene or firewood in those homes? So that was the beginning of my adventure. When I came back and looked at the literature, and I told some of my colleagues, do you know that people who cook with firewood, that 3 million people die every year? They looked at me and said, no, come on, stop messing with us. Nobody, at least most of my colleagues in pulmonary, this was about 12 years ago, didn't believe or know that this was such a big problem. But to put it in context, more than 3 billion people in the world, half of the world's population, actually cook with firewood because they don't have any other thing to do to cook with. They cut down all the trees. And it's the incomplete combustion of cooking either with firewood or dung that leads to the household air pollution with emission of carbon monoxide, particulate matter, polycyclic aromatic hydrocarbons, all of those bad things that people inhale. And 3 billion women and young children are most exposed because in a lot of those low-income country settings, the women stay at home, they're responsible for the cooking, and before the kids are old enough to start walking, they hang out with their mothers in the kitchen. So that's why when you look at mortality related to household air pollution, it's mostly in women and young children. And if you look at exposure to household air pollution, ambient air pollution, it accounts for about 4.2 million premature deaths every year. This is 7.5% of all mortality, and over 100 million dailies. This was in 2015. And when you look at household air pollution separately, this accounts for 2.5 million deaths every year and 85.6 million dailies. This was in 2015. Together, this accounts for preventable, almost 7 million preventable deaths every year. And this is responsible for over 3% of the global burden of disease and a major contributor to the environmental degradation and climate change. And if you want to really stretch it, some of the pandemic that we're dealing with, because we are narrowing the interface between humans and all of these animals. So all these viruses can jump from one population to others. So this is in a way, in my mind, and in most people, mostly related to this climate change issue. So sometimes people think that the problem with household air pollution or ambient air pollution is only a problem that's out there. And that perception has actually made it difficult to invest wisely in a way that can stop people from cutting down trees, so that the pollution that comes from India and Nigeria and Africa, it's going to get here. So whether we're here, whether we're close to them or not. But I thought I'll share this information with you to let you know that household air pollution and ambient air pollution is a major problem also here in high-income countries. This is, I don't know how many of you have been watching The Crown and the episode when Churchill was the prime minister. They had a cold invasion in the United Kingdom, London, in 1952. And this is what it looked like at that time. Over a 1-week period, there were 4,000 people dead, including Churchill's assistant, because he didn't believe that he was killing anybody. But it's not dissimilar to the situation that we face in our country now, until his secretary actually died. He didn't believe it. The PM levels at that time were estimated to be over 1,000. To put it in context, the WHO standard is about 35. So most of the mortality around that time were related to respiratory diseases, especially asthma. But cardiovascular event was actually the biggest cause of mortality at that time. And this led to the enactment of the Clean Air Act in 1956. And we didn't do it until 1970 in the United States. And this is also a very intriguing study. It's the Harvard 6 City Studies, where a cohort of over 8,000 adults from about 6 cities listed here, Portage, Topeka, Watertown, Steubenville. They were followed for about 14 to 16 years while monitoring the exposure in those areas. And there was correlation between PM levels and mortality. And the residents of the most populated city had 25% increased risk of premature mortality compared to those in the least polluted city. And you can see that here. We're talking about being polluted. Remember that the WHO standard is 35. The experience I showed you in the UK, where the PM was over 1,000. Steubenville, Ohio, that had the highest ambient exposure level, was at 46. And you can see the graphic here. This is looking at the years of follow-up, 14 to 16-year follow-up, and the probability of survival. And you can see that Steubenville, with the highest ambient pollution level, is a setting where the mortality rate, the risk of the likelihood of survival was lowest. And when you look at the causes of mortality in current smokers, former smokers, and when you look at the most versus the least polluted city, you can see that lung cancer, 8 times more likely in current smokers, even in non-former smokers, 2.54, you can see. And then cardiopulmonary disease, look at the percentage of the total. And you can see that this is really a dangerous problem that is under recognized. So this is looking at the global burden of disease data from 2015, reflecting on factors between 1990 and 2015. And you can see that in 1990, ambient mortality related to ambient air pollution and household air pollution were numbers 4 and 5, higher than issues related to diabetes, cholesterol, and all of those. In the new rendition, you can see that ambient air pollution has moved down a little bit, but household air pollution is still part of the top 10. So it continues to be, they continue to be a source of threat to our livelihood. So it's also important to introduce the concept of energy poverty. This is the reflects lack of access to electricity in developing countries. And when you look at LDC here, is the least developed countries of the world. SSA is sub-Saharan Africa. And unfortunately, most of the least developed countries in the world happen to be in sub-Saharan Africa. So that you can see in blue here, these are places where rural areas where they don't have access to electricity. The urban setting, even the urban setting in these places, they also have epileptic power supply. And if you look at where this is a big problem, it's in Africa, India, and Southeast Asia. And this has implications for life expectancy. If you look at Human Development Index, you look at the United States here with HDI of 0.92, and at the bottom, you look at Nigeria and Ethiopia. Look at the differences in the life expectancy, 51.4 to 78 and 80. So this is a big, big problem. So this is what the energy ladder looks like from the very, very most poor countries all the way to high-income countries where we have access to electricity, natural gas, and then crop waste and dung. I'm sure people haven't seen dung before. These are pictures that I took myself in Bangladesh. You know, you can see some of these sticks here. This is wrapped with dung. This is animal dung, animal shit, right, wrapped around trees to make it more potent. And you can see the waste that they've collected here as a way of making sure they have access to cooking fuel. Occasionally, they put it on the back of trees. When it dries up, it comes out like a cake, which they put into the fire. That's what people cook with. So unless you know this and we intervene, we're going to be dealing with the problem of climate change and environmental degradation for a very, very long time. So the pollutants that you get from cooking with some of these fuels include carbon monoxide, oxides of nitrogen and sulfur, black carbon, particulate matter, even carcinogens such as polycyclic aromatic hydrocarbons. And also a major source of the problem, especially in the lungs, is adherent metals, iron, cadmium, lead that are adherent to particulate matter, so that when you inhale that, particulate matter can also instigate inflammation. But these adherent metals also on their own can trigger inflammation that becomes generalized and responsible for a lot of the damage that you see from exposure. So why is exposure also so dangerous to women and children? I mean, the picture is worth 1,000 words. This is what it looks like when these people are cooking. You can see the intimate proximity to the smoke, and you can see these little guys here at the back, either sleeping, but they're breathing the same. That's why the mortality from exposure to household air pollution, 30% of them is in children who are less than 5, who die from acute lower respiratory tract infection, which is very, very preventable. So this is, and this is in Nigeria, this is in Bangladesh, in India. It's the same thing. Poor people have the same attribute because they must cook for their families, and this is all they have. So in terms of the diseases or conditions associated with this exposure, again, this is looking over the same time period, 1990 all the way to 2015. In this light pink color, you can see this is cardiovascular disease. Most people, even pulmonary folks like me, think that my exposure to household air pollution, the biggest problem is actually going to be pulmonary. But the biggest challenge that is associated with exposure to either ambient or household air pollution is actually cardiovascular. Next here in the gray is ischemic, cerebrovascular disease. And in yellow, this is pulmonary. You can see it's constant over time. And then in the blue at the top are the lower respiratory tract infections. So why does exposure to air pollution pose such a huge cardiovascular risk? This is a setup by one of our colleagues, the chief of pulmonary at the University of Chicago, Gokhan Mutlu, with this exposure system where he exposes animals to filtered air with PM level at about 100. This is about 3 times WHO standard. And then filtered air. And then he's done some of this elegant work to look at bleeding time, to look at platelet count, partial tromboplastin time, and prothrombin time when animals are exposed to particulate matter versus controls. And you can see that this exposure causes a prothrombotic state. That's why you have a lot more coronary ischemia and cerebrovascular changes. And part of the work that they also did was they did lavage in all of these animals to demonstrate that IL-6 is a major driver of some of the changes, the inflammation that follows this exposure. And they also looked at the time, how long it would take for coronary arterial blood flow to cease in these animals. And you can see that within a short period of time, coronary artery flow ceases, which is why it's very easy to understand why people will have strokes and heart attacks. And the human component of this is in this study that was published in New England Journal in 2007. As an ethicist, I don't really know how they got permission to do this. But what they did was they looked at 20 men with prior myocardial infarction, and then they exposed them to diesel particulate matter with PM levels as high about 300, which is almost 10 times WHO standard, and filtered air for 1 hour. And then they did post-exposure stress test. And this is what it looks like. In terms of just with that little exposure, you can look at the ST segment depression in filtered air versus those that were exposed to coronary ischemia, expressed this way, and you can see here. So now you understand that. I hope it's clear that both in animal studies and human situations, that exposure to household air pollution or ambient air pollution, especially on ozone days, when they say high ozone days and advise people not to go out, this is one of the reasons, the dangers that it poses to people with underlying cardiovascular disease and also people with underlying pulmonary diseases. So what I was, haven't been ticked off by this experience, I got a humanitarian award from the Chest Foundation a long time ago, and I decided I would go back to Nigeria to do a case control study in a few homes where a mother and a child that was older than 6 years old, I was going to look at indoor air quality 1 hour into cooking to look at particulate matter levels, to look at the frequency of symptoms on exposure, and more importantly, to be able to do pulmonary function in the women and the children. And I used that $25,000 to buy these rocket stoves that are lined with ceramic that can heat to 300, 400 degrees so that there is more near complete combustion. This is what the rocket stoves look like, so that without imposing any economic burden to them, they're still using firewood, but it produces less smoke. And if you look at the walls here, you can see the effect of chronic exposure to some of this stuff. So on this graphic here on the left side, this is PM 2.5 level. The bar here, the clear ones, is just looking at ambient exposure level in the households before they start cooking. And the high level should give you an idea of how poor the air circulation in these homes are. For people who don't have the concept, I mean, who may not know, a lot of the rooms where we're in, you need to have 6 to 8 air exchanges every hour for it to be safe for us to stay in. You can see that at baseline, they even had PM levels from the last cooking episode that's already high. 1 hour into cooking, PM 2.5 level, this is 5,000. And being there, I couldn't stay there for more than a few seconds before coming out. It's amazing how people get conditioned to stay in those conditions when they don't have any choice. So after the distribution of this rocket stove, you can see there was a dramatic reduction in improvement in indoor air quality. You can see that the ambient exposure before, when not cooking, remains high because they don't have chimneys, they don't have windows that helps to promote circulation. On the right side here is carbon monoxide level. I don't really know how people are being able to condition with PM CO levels this high, but the stove was actually more effective in nearly eliminating the carbon monoxide associated with cooking. So the pulmonary function test in these mothers, you can see that about 30%, 30 to 40% had mild to moderate obstruction. Just think about it. People don't smoke in Nigeria, especially women. And in these children who are about 6 years old, this is, look at this, almost 40% with mild to moderate obstruction, which doesn't augur well for pulmonary growth in the future. We went back and did pulmonary function test almost a year later. The only thing we didn't do that I wish we could have done was we didn't do a post-bronchodilator response, but you can see here that there was really no interval change from the baseline obstruction that we found and a year later. So we concluded at that time clearly that PM 2.5 is a major pollutant from cooking with firewood. Clearly, the women and children are at the greatest risk. It's associated with obstructive lung disease. And the improved biomass stoves, even though they improved indoor air quality, the residual level was still 5 times above WHO levels and posed ongoing health problems. So what I did then was I just couldn't stop there. I tried to figure out if there was a stove that would burn better and improve the indoor air quality for these folks. So we did a randomized control ethanol stove intervention and pregnancy outcome study. This is very important, the way we structure this using pregnant women, because in a lot of these low-income countries, the governments don't really care about their people. Otherwise, they would have invested a lot more. And I have a health policy background, so I figured if we did this intervention and if it was successful, most people have women at home, most people want to have children, that maybe we would have a chance in terms of improving health policy. So that's why we designed this study in such a way. And what we decided we were going to do is, this is the firewood stove. People just, this is the traditional stove that people cook with. They put firewood there. And this is the kerosene stove because it's liquid. People assume that it's actually clean. It is not. And this is what we decided we were going to give them, which is like a Tesla of all stoves. It's It's aluminum. Some of them are stainless steel, and it uses alcohol, ethanol. And I realize those of you who may have boats, you know that people who have boats, you use ethanol-based fuel on their boats. So the main research questions that we had were, what is the relationship between exposure to household air pollution during pregnancy and birth outcomes? And the secondary research questions were, can ethanol intervention affect blood pressure during pregnancy? Can ethanol reduce personal exposure to particulate matter? Does it trigger oxidative stress? And will participants use and adopt these ethanol stoves? I got the funding to do this study from the United Nations. So there are many, many areas, non-traditional areas, where you can get funding depending on what you want to do. That's global health. This was the hypothesis that we had. Clean cook stove and bioethanol will reduce pregnant women's personal exposures to PM 2.5. Analyzing polycyclic aromatic hydrocarbons, very, very expensive, but we did it in a small cohort. And then carbon monoxide, we ran into a problem because we couldn't get a way to get CEO to calibrate instruments, but we still had good data on the PM 2.5. What we did was we excluded women who had a smoker in the home, very rare in Nigeria, women who cooked for a profession, people who had HIV infection or anything that could lead to intrauterine growth retardation or restriction, high-risk pregnancy. And so we ended up randomizing 324 women, one half into the clean cook or intervention stove. I was interested in using just kerosene, but the sponsor, they stopped us and wanted us to create a firewood group. So that's why you have this breakdown between kerosene and firewood. And I had no idea how expensive ethanol was because I didn't include it in the budget. I didn't have any idea how expensive the clean cook stove was. It cost about $50 each. But through the network, we got somebody to give us these stoves for free. And Shell actually gave us ethanol throughout the study, over 50,000 liters of ethanol. And the last delivery for this study was in August of 2015. When you looked at the participants and the groups, you can see here with our randomization that we did a good job, either in terms of age, whether they were married or single, the gestational age at recruitment. We used ultrasound to determine gestational age. And then we did ultrasound at 6 different time points. I don't have time to talk about intrauterine growth rate but today, but that was what we did 6 times, so that for each pregnant woman, we could plot the trajectory of the growth of their children. And then we captured all of this stuff. We were interested in whether malaria was a problem, headaches because of the carbon monoxide, burning eyes, standard stuff, and you could see that the two groups were very comparable. This is what it looked at. We enrolled women in the first trimester. Randomization was done in 18 weeks because people don't actually announce they're pregnant in Nigeria because most people lose their pregnancy. So you don't say anything until it's obvious. We did personal exposure monitoring in these pregnant women in the second and third trimester of pregnancy for 72 hours. And we also, they put inside this pouch here is the microPEM monitor that we used. We also had a GPS monitor there because we were interested in indoor versus outdoor exposure. And on these stoves, to measure or determine compliance, we put a coin-shaped stove use monitor, which is a thermo-sensitive probe that would let us know whether they were actually using the stove or not. And to make sure that we got objective data, we put this on all the stoves in the household. So even though we gave them the clean cook, we put it on the traditional stove. We put it on the kerosene stoves too, so that we could be sure. The first thing that we did to test the effect of the intervention, to be sure that it's going to be real, is we looked at data from the stove use monitor in our intervention group. And you could see that they actually stopped using their kerosene stove and adopted the ethanol stove. Because if we are not able to show that they actually adopted the ethanol stove, all of our hypotheses, all of our outcome data will be suspect. And you can see the control group, they had nothing to use. So this was very, very fundamental to the study that we launched, to be sure that we actually got people to use the stove that we wanted them to. And it didn't hurt that every 2 weeks we provided a supply of ethanol to this group and gave them a stove that actually raised the socioeconomic status in their community just by having it. So what's the relationship between HAP exposure, birth weight, and other pregnancy? One thing that I'm not going to talk about today is we actually did a lot on this study. We collected blood samples to look at micronutrients, to look at nutrition, because we believe this is oxidative stress driven. So we were interested in antioxidant defense. So we did IL-6, we did CRP, we did TNF-alpha, IL-8, albumin, pre-albumin, to try and see whether good nutrition had a protective effect on the outcome of our study. So this is what the exposure looked like. To up the front, I'm happy that we actually did this GPS monitoring, because people just don't stay indoors. Outdoors, because of the dust and automobile exhaust, 69% of the exposures we actually could attribute to indoor exposure, looking at GPS monitoring of their movement. And there are also seasonal differences in exposure levels, being much higher during the dry season and lower in the wet season, because the particulate matter is in the air, and when it rains, it just blows it away. And this is the turquoise is the intervention group, looking at the kerosene subset during the dry season. And you can see the intervention did reduce, but when you are dealing with about 30% exposure ambient, it was difficult to be able to really have anything more than this. The 3-stone group that were cooking with firewood, compared to, you can see, the trend held true. So it's actually quite interesting that we were still able to see significant changes based on the randomization. This is what the mean birth weight looked like in the ethanol intervention group versus, so we had almost like 80-gram difference between the ethanol and the fire group, one group, but the difference was not significant. But what was striking to us was that the intervention group were actually able to take their pregnancy to term in a striking manner than the kerosene and the firewood, the combined control group. When we looked at the premature delivery rate, strikingly higher in the control group, the same thing with miscarriages, stillbirths, and neonatal deaths. So this is what the birth outcomes looked like. One other thing that we did was we tracked blood pressure all throughout the pregnancy to align with the times when we were doing the ultrasound. And if you understand pregnancy physiology, there's usually a lot of vasodilatation, blood pressure drops, and then it goes all the way back up. And if you look at the control group, near delivery, about 6.4% of the women in the firewood developed hypertension. Nobody had hypertension at the beginning. relative to about 1.9% in the ethanol users. If you looked at kerosene alone, it was the bad player in that almost 9% of people who were on the ethanol actually developed hypertension. And you have to put it in the context of the importance of preeclampsia in fetal mortality or even maternal mortality. This we published a few years ago. And then in terms of the inflammatory biomarkers that we measured, I'm going to show you the TNF data, which we believe TNF drives IL-6 and all of those. You can see that in the kerosene group, much higher than in the ethanol group, where it was significantly lower, maybe protective in that context. This is just showing exposure-related symptoms in the different cohorts, and it gives you an idea of the impact of being a participant in studies. This is looking at headache, and the red here is baseline and control, both for the intervention and control group. And you can see that the intervention group, they had less headache, even though the control group also had a significant reduction in some of this exposure. This we attribute to the fact that even the control group, because of the ethics of it, we actually provided some education on guidance on how to reduce exposure during cooking. So that's why you can see that this led to dramatic reduction in symptoms. This is probably the most sobering of the work that we did, because while we were there, we decided we were going to look at the placenta and also collect cord blood to see whether we could see changes in angiogenesis or what the placenta would look like. So this is histologically, I have a colleague in maternal fetal medicine who is very interested in preeclampsia and was collecting a lot of placenta.
Sorry, I couldn't hear what you said.
Oh, Siri, I wasn't talking to you, Siri. So sorry about that. So the yellow bar here is placenta from African Americans in Chicago. The light blue here are the intervention group in Nigeria, and the black is the control group. And when you want to look at histology of the placenta, looking for hypoxia, you're looking for Hofbauer cells, chorionic vascular density, and syncytial knots. And you can see it's a no-brainer. The most exposed, when you look at the placenta, you can actually see histologic evidence of hypoxia in the placenta of the most exposed women, okay? Whether, depending on, regardless of the indices that you used. We then went ahead and thought, see if we could look at HIF expression in the placenta in these women. And A here is the least graded as low HIF expression, moderate expression, and high expression. And the bottom row is the corresponding computer rendered images. And looking at the quantification, you can see that the most exposed women, but also the kerosene group, there was a tendency to have higher expression of hypoxia-inducing factor relative to the Chicago African-American cohort or the intervention group. And this has significant implications, because if you look at poor people who cook with firewood, get pregnant, the children develop in a hypoxic state, it has implications for their cognitive development as they grow up. We also looked as for biomarkers of angiogenesis, and usually when people get pregnant, you develop some of these angiogenic factors that promotes new vessels in the uterus. And then just close to delivery, it's like everything stopped. There's regression, so that when people deliver, you don't bleed out. And I don't know how many people know, but postpartum hemorrhage is the biggest killer of women, both in Nigeria and India. India has the highest number of postpartum hemorrhage related to pregnancy, and next to that in Nigeria. So we were wondering, what we saw was inability to actually retard angiogenesis. So it appeared to me that people were actually trying to compensate for the low hypoxia in the placenta by generating angiogenic factors, so that those that succeeded in having the babies, they might be smaller. Those that didn't succeed died, but we didn't have access to some of those placenta samples. So in summary, clearly we were able to demonstrate that ethanol stove reduced personal exposure to particulate matter. Cooking with kerosene and firewood adversely affected pregnancy outcomes, and the ethanol stove intervention had health benefits, not only in terms of reducing pregnancy outcomes, but also in terms of the blood pressure effect by reducing the risk of preeclampsia. The adoption of the clean cook stove was very, very high, because after the study, about over 80% of the women chose to start cooking with ethanol by buying ethanol. And of course, from the ethics perspective, we gave these $50 stoves to all the women in the control group. And we were able to show that exposure to household air pollution during pregnancy is associated with chronic placenta hypoxia. And this actually is the topic of the, we have a new R01 because we've continued to follow this cohort of children for the past 4 years. And the idea is to look at cognitive development in these children for the next 5 years. So we're just ramping up. They're about 4 years old now. So we're going to treat them as a discovery cohort. We're going to get another, we're going to have another cohort of children that will be a validation cohort to see whether in utero exposure to household air pollution is associated with cognitive changes. Going forward, what we're doing is, like I said, we have this new R01 to test the impact of this in cognitive development, to look at the impact of exposure on air pollution or maternal-child outcome on the south side of Chicago. I'm going to tease you with this observation that we did. This is, we have these smart monitors that we deployed on the south side of Chicago, including Hyde Park, where the University of Chicago is. And then we simultaneously also deployed it in Nigeria, and the data was stored in the cloud. And you can look in some of these Chicago homes. This is Nigeria here, 1,400, the maximum. This is the maximum looking at range. There's some homes near the University of Chicago on the south side of Chicago. This is indoor levels. This is indoor levels of particulate matter in Chicago. 1,600, look at it, 153 in Chicago homes. And the question is, why is this the case? And when you put it in the context of, this is what's happening in Chicago. Chicago pre-term delivery rate is 2 times the American standard. Infant mortality rate is one of the highest in the country. And there is a 14-year life expectancy difference between downtown Chicago and south side of Chicago. So what we're trying to do is see if we can reproduce what we've done in Nigeria, to look at south side of Chicago to determine whether environmental factors actually account for the differences in life expectancy, or whether we can also reproduce what we found in Nigeria with in utero exposure to household air pollution as a major risk. And I'm sure most of you might be wondering why that might be the case in the south side of Chicago. This is because in poor communities, when you live in cold climates, like say, if you have a draft where cold air comes in, the home environment is cold. Over time, what people have done is they use their stove, their gas stove, they turn them on as a way to supplement heat, inadvertently causing household air pollution. If we are right and we're able to demonstrate seasonal differences from the pilot studies that we're doing, we might be able to just do public service announcement to tell people not to supplement heat during the winter months by turning on their gas stoves. I'll stop here and take any questions that you guys may have, but it's been a pleasure being able to tell you what I do. I hope it's touched on an issue that most of us may not be very, very familiar with. And this is my team in Nigeria, includes people from here and a lot of people that we've trained in doing research in Nigeria. So thanks for the opportunity.
Yeah, thank you so much for really, really appreciate bringing to light the significant impact of ambient air pollution on health. And it's really impressive how diverse the adverse health effects are. Pick any organ system, you will find impact. And the fact that it is not simply isolated to low-income countries. It is, really one of the factors that contributes to healthcare disparities, even in the U.S.
Yes.
And so a couple of questions have come up. One, actually related to a question I had as well, is while you showed uptake of the ethanol stoves, for example, in your pilot studies, what do you see the challenges for more widespread implementation and adoption of some of these new technologies, if you will, or new methods for cooking in Nigeria or other countries?
This is actually very, very important and astute question. What has happened after this study was the Nigerian government actually removed the subsidy on kerosene. They used to subsidize kerosene. So they removed the subsidy. So as a policy person, that made my day. The other important part of it was Shell actually decided to do a commercial pilot of distributing these stoves in Lagos, Nigeria. And you remember during our conversation last night, I told you we actually have an implementation science R01 grant that we wrote to the NHLBI that got a priority score of 20. So, and the idea is to be able to actually implement, scale up the distribution of this and work with the Lagos State government to look in the communities to look at the potential impact on hypertension while distributing and trying to make sure that people can adopt these safe stoves. So that's really a very good question, and it's totally aligned with what we are planning to do. And with that funding, I'll be ecstatic being able to actually distribute these stoves, encourage local production of ethanol and local fabrication of the stoves in Nigeria. So this is research influencing policy and entrepreneurship and dealing with an issue that is global.
Great. And then at the completion of your study with the ethanol stoves, did you continue to provide ethanol for those participants? And can you comment on the cost difference between the different fuels in Nigeria with and without the subsidy?
What we've done is to maintain women who are in the control group. What I forgot to mention, which is also interesting for people who do behavior or social sciences. We went there to do regular science, but when we asked the women why they adopted the stove after the study, these were their reasons unrelated to our health outcomes. Number one, their pots and pans were not getting black anymore. They could stay in the kitchen without, choking. Their children could stay with them. It made them as if they were in a higher socioeconomic class, because you look at that stove compared to firewood that people were using. Number 4, these stoves actually last about 8 years. They would otherwise have to change all of those kerosene stoves after about 18 months. And then the other thing was the cost of, so that's what, so because behavior change is difficult, but when people perceive benefit on their own, they will adopt it. So what we've done is we've been investing in actually getting the ethanol in the depot that we created, and we've made it, subsidized it so that it will be lower than the price of kerosene. $1 is about 450 local naira, so it's about 200. It's about 50 cents for a liter, and we know that 10 liters of ethanol served a family of 4 to 5 for about 2 weeks. In fact, we have data on the economics of this work, because we were taking ethanol to them every 2 weeks. We were measuring, so we knew how much ethanol. We were trying to look at the economic cost of, clean fuel compared to the other ones. We just haven't had the rigor and the time to tease this out, but we do have all of that data. But people have, so for 50 cents for a liter, that's what those women have decided was worth their own life, and maintaining the status and helping them to stay in a dust, in a pollution-free kitchen.
Great. A couple of questions about what was your research team's interaction with government in terms of trying to influence policy, both whether it was in Nigeria or in Chicago, and your experiences with that?
We work with local NGO organization that's we worked with for about 10 years, so that this is where our students stay when they go to Nigeria. This is where we also stay. Nigerian government is very, very corrupt. So what we've actually done is to just do our work. I have a friend who is the commissioner for health for Lagos State. So I talked to him when we were drinking beer, and he did his MPH at Johns Hopkins. So he's taking this data and wants to use it to implement change. That's why our implementation science R01 is actually in Lagos, to look at the 52 community centers there, because we have to work with government to be able to implement at that scale. But that's how, the reason I went that way is because I knew somebody there who was committed and telling me, I'm the person you should be giving this result so that I can use it. So when we're doing this implementation science project, he's one of the local co-investigators. So that's what we've done. And then we've published this. We've used social media in Nigeria to bring it to people's attention. And I think that might be a way responsible for some of the removal of the subsidy on kerosene.
And these are
in Chicago, we're still doing the pilot. We have a gut feeling that that's what's happening, but we haven't proven it yet. But we've been able to demonstrate the data that I showed you in Hyde Park. The indoor PM level is like that 17, 16. So you know that in places where people have wealth, there is no indoor air pollution. But if you go to the south side, if you go to the west side, that's where you see these high levels. And that's why I said I'm actually excited if we're able to see a seasonal dichotomy in terms of premature deliveries that's locked to the winter period. we can just go out and say, wait a minute, guys, you are killing yourself. And a way to also look at it is if babies are actually growing up in a hypoxic state, if our R01 on cognitive development is able to confirm that this is actually cognitive development based on in utero exposure to house, they cannot be smart. So the onus is on us to make sure that we can take people out of poverty simply by improving the household quality, because their children and their offspring, if they're exposed to hypoxic setting during pregnancy, we have a generation of children who are not going to be smart for no fault of theirs. So when I look at this from the policy perspective, I'm very happy that this serendipity happens just by going to do hygiene hypothesis study in Nigeria. Otherwise, there is no way I would have done any of this work.
Great. And I will give the final question to Dr. Jajor.
So, Sola, a very quick question about whether you discovered any genetic or other characteristics that are protective in those who are exposed.
No, for this particular study, we actually I didn't do, every time I go to Nigeria, I always do DNA extraction. I didn't on this one, but what we looked at were just the micronutrients to look at antioxidant defense to see whether, because if you have minimal exposure, we all have antioxidant defense. I mean, we believe this is driven by oxidative stress. So if it's minor exposure, which is probably what all of us deal with in America, it's not being exposed to 5,000, then at that level, then you can, your antioxidant defense, even from the pulmonary perspective, can protect you by just the free radicals, just mopping things up. And it also, through epigenetic changes, might allow you to actually start producing some of those protective, changes. But we didn't do any epigenetic stuff for this project, but it's something to think about going forward for sure.
Great. Well, again, thank you so much for a wonderful overview and for taking time yesterday to meet with some of our junior faculty and trying to engage them in thinking about global health more globally. And look forward to meeting you in person at some point in the near future, hopefully.
Same here. Thanks for having me.
All right. Take care, everybody. Bye-bye.
All right. Yeah. Bye-bye.